Welcome to the Health System CIO show. I'm your host, founder, and editor-in-chief Anthony Guerra. On today's episode, I'll be speaking with Dr. Bob Jarve, Associate CMIO with Corewell Health. Dr. Jarve, thanks for joining me today.
It's my pleasure. Thanks for having me.
All right, great. You want to start off by telling me a little bit about your organization and your role?
So Corewell Health is a large health system in integrated health system in Michigan. It is a combination of the legacy Beaumont Health System that was on the east side of our state and legacy Spectrum Health System on the west, as well as Lakeland Health in the southwest. There's approximately 23 hospitals. We're the largest employer in the state of Michigan. We have an integrated payer with about 1.3 million lives, and we have probably 3.2 million active lives that we care for within our delivery system.
All right,
And
and go ahead. Yeah.
and I am a primary care physician by background. I'm internal medicine and pediatrics. I still practice one day a week in our high risk underserved clinic, which services patients who have severe mental illness, substance use disorder, um, social determinants of health needs, and are high ED utilizers. And the rest of my time, I'm the Associate Chief Medical Information Officer / Medical Director for Pop Health Analytics and Insights, and work to lead the strategy build out of our analytics for population health and how we're going to get insights on those data and analytics sets.
All right, excellent. So we're chatting today about an internal population health platform that you built, and we'll get into these terms, terms like platform, and because we got a lot of platforms out there. I know you're an Epic shop, which I guess
Yeah.
is a platform, or an I know it's an EHR, but I don't know, what platform means. We think of that as a platform. So if you got a platform, I'm trying to understand that. I'd like to talk more about how platforms work together and then versus niche one-off solutions that are outside and integrated. And these are all decision points, architectural decision points that
Mm-hmm.
you have to come up with, right? In conjunction with
Yeah.
sort of the clinical needs you're trying to achieve, the population health needs, the IT architecture that's in place, investments that have already been made, integration, data flow, all kinds of stuff. So there's many ways these things can be constructed, right? From the initial, we want to improve our services in a particular way, from that initial desire to how it ultimately comes to fruition in terms of the structure and the actual tools. So that's fascinating. So let's talk a little bit about that, and you could start wherever you want and just take me through that journey of, again, quest for improvement to ultimate architecting of that improvement.
So, I will say that my first journey in this was we did go with we've gone with a couple of vendors, but we went with a vendor very early on in my career. It was probably looking 10, 12 years ago. And the goal was to have a vendor that was going to take all of our data and and deliver us with a population health data model and visualizations and the ability to do population health and quality in the ambulatory setting. And it was a complete and utter flop. It did not really work the way that we intended. And there was a lot of lessons learned in that. And one of the lessons that I learned was that, the difference between what is complex and what is complicated. And what I mean by that is I have since then really focused on when I have a complicated problem, like um, claims groupers. I'm going to find a vendor because if you can do that, it's rinse and repeat. It's not really different from one organization to the next. But most of the data within our hospital system from a clinical standpoint is a complex problem. And the example I give is if you've been in a hospital like our Beaumont Hospital that's been around for 150 years or so, and you figure out how to navigate that hospital now and where all the different places are in that hospital and how you get from point A to point B,
Yeah.
you figured out a complex problem. But it will do you no good when you go to another 150-year-old hospital down the street because those hospitals built up ad hoc over time based
Right.
on what the needs were, and there's no standard layout, and so you have to start all over again to figure out how to navigate a hospital. That's the same thing in a lot of ways when we're looking at clinical data within our EHRs. Our hospital system service lines have all been created in different ways. The structure of our teams are created in different ways. how we document in the EHR, even though we have Epic, how we document certain things like ejection fraction or PFTs, those are all created in different ways. They're not standard across different hospital systems. And so even the matter of how we define who's a patient in our practices is different from hospital to hospital. There's no real standard. And so when we went out to create this data model now, we really realized it was a complex problem. And so we built it out internally as a patient-centered longitudinal data model that's got a specific unit of time of a month, and we did it on our entire active population so we could understand over time what's happening with these patients. And the reason we did this data model too is one, we knew we had to build it because we knew the data pieces that we were putting in there were going to be unique to us, and we're not going to be things that a vendor is going to want to spend a lot of time building out custom work on. But the other reason we knew we had to build it is because EHRs are designed for a fee-for-service world, and they're designed for the world that has existed for the last 50 years or so. And what I mean by that is lab data is set up to be understood by the lab, and it's set up in episodes of CVCs done or GFRs done. It's not set up longitudinally over time at a person level, so you can understand how many CVCs did the patient have and roll that up into a, fast into a population level aggregate. EHRs are good at doing that at the point of care with a single patient, but they're not good at ramping that up for 800,000 patients. And so we had to build that out, and that's really where this started from, and where we and why we built out the model that we built.
Yeah, so your one of your core points in there is that some things you just have to do yourself, or you should do yourself and internally, because they're just too complicated and complex. And I know there were some nuances there, but um, to communicate, and you said the interest on a vendor, because if I do all this work with you, I can't really replicate this. I can't leverage this for future customers. So it's going to be super expensive because it's kind of a one-off.
Right.
And even then, there's going to be so much communication. It's almost, I get it. It's like some things you just have to do yourself.
Yeah, it doesn't scale for the vendor. So it's very hard for them to see the ROI on trying to do that kind of customized work. And so you really have to do it yourself.
So we didn't want to go with a point solution outside of Epic. And when we talk about the way the EHRs are made, should we take from that the idea that Epic did not have a native module that you were like, oh, we just turn this on. Let's use this. It's in the suite and we're good to go. No, you looked at what was in Epic, not quite right for all the reasons we just discussed, certainly not going outside of Epic. So that means it's time to build, correct?
Correct. And we had many conversations with Epic, letting them know what it was we needed, and they just were not there at that point. And they were very clear that they weren't going to be there for a while. That wasn't where their focus was, and so we did start to build this data model out internally. We do, and it is in Epic. We are an Epic first shop. It is we leverage a lot of the functionality within the Healthy Planet suite of Epic for population health, but we tweak it and we make it so that it's going to be able to do what we need. So, and one of the things we've learned really early on is we will leverage Epic's registries that are in their Chronicles database, which is their at the point of care, to build our metrics, but then have those flow down into Caboodle and into our PHDM so that when we find insights, we can create targeting reports at the point of care that are real time, that we can drive those insights to our care teams can drive those insights to the patients that we want them to.
That's absolutely brilliant. And that is, I just read a great article. We're gonna run it in our e-newsletter this week by Dr. John Lee. He's doing incredible writing about Epic, and making use of Epic.
Mm-hmm.
And he talked about that dynamic of sort of third-party apps that don't that do not are not interacting with Chronicles. And if
Yeah,
they're not interacting with Chronicles, they're not propagating that kind of learning and that systemic effect across the applications. And they're just, when you have to remember to go outside, to go back outside, and do something with the alert you received from that third party, that's a big fail, right?
It is a
It's
big
got
fail.
to get into Chronicles, and it's got to then, it will have the systemic effects.
Yeah, and it has to be integrated into the workflow of the teams so that they can easily like you got to reduce the cognitive load for the teams. They're busy. They're trying to do a lot of stuff, and so this needs to be something that is just intuitively helping them do their job better versus a thing they have to try to remember to do to improve care.
The way I always think of, I mean, the way I think of it is, I remember when I was a kid and I used to, sort of dominoes. I used to get my parents to get me dominoes, and I'd build those dominoes that where you knock one over and it knocks the rest over. And if you had a gap, nothing
Yeah,
happened, right? So
right.
that's how I think of workflow. That's how I think of everything we're talking about here about Chronicles. It's that when you get things into Chronicles, um, the dominoes are going to fall, and you're not going to have a gap. If you're outside the workflow, you have a gap, and sort of, does that make sense? Is that a way to
Yes, it
think of
makes total sense.
it? Yeah.
Yes.
So it's just it's fascinating. Question about your build. Um, I've heard this said that because of AI and because of the LLMs out there and the models and things like that, building is easier than it has ever been before. They facilitate building, and there's another reason to sort of do things yourself more than there used to be. What are your thoughts on that?
I think it's a yes. It's a yes and a no. Like so, it depends on where we're using it. I think AI is a game changer. As these LLMs, like we have a bridge within our system that is an ambient AI that's collecting all of our information and creating a note in the visit. It's been a game changer. It's significantly cut down pajama time. It's significantly cut down, physician burnout, and it's much more accurate capturing of the data that we want. But it's all in a note, and so then you have to then use the LLMs to pull that data out at the back end. So there's an upfront early learning curve of how do we get that data back into discrete form in a way that we trust now that we're using the LLMs as the ambient AI. I think with code and stuff, LLMs are going to be a game changer. It's early. I think there's a lot of we're starting to use that within our organization more and more. There was a lot of hesitancy early just because of HIPAA and like you want to make sure these are closed systems and that what you're doing is not getting out um, side of your four walls, so to speak. But I do think that's going to speed up the quality at which we're able to do things. We're looking at putting LLMs, for instance, on top of our population health data model so that we can actually just query the PHDM for doing pop health assessments, where it will write the SQL queries for us, and that's going to speed things up quite rapidly. So I do think it's going to speed the process up and make it easier, but I think we're just at the beginning of where that's happening, at least in our
Let's
organization.
Right, right. Let's talk a little bit about the ambient AI. And you mentioned Abridge. There's a number of vendors there. Um, I just find and you maybe you could tell me what Epic has for ambient AI and where it stands. Obviously, to a certain extent, you have to say they kind of maybe missed the boat here a little bit. There should be, if you think about it, there should be zero third parties playing in the right. There should it
Right.
can right. There should be zero. This should be a native Epic tool, and the fact that it's not is kind of stunning. I don't know if they're trying to catch up, because we talked about third party and Chronicles and all these kind of things, and you mentioned your vendor, and a lot of
Yeah.
people have outside vendors. I find this fascinating. What are your thoughts?
I do think they kind of missed the boat on the on AI, and I think they missed the boat on AI in a lot of places. Not just with the Abridge. I mean, I think that they're trying to play catch up with on the back end too. Now, I think they're large enough, and they are you know really putting a lot of effort to catch up. And given the way that I've seen them catch up in other places, I think that their odds are good they will get there. But they did miss the boat a little bit on this for me because I agree with you. They should have just native AI in there for this ambient AI
Oh,
technology without having to go to a vendor that
hey,
is
Dr.
way
Jarve,
smaller. Man, are you
Dr.
there?
Jarve,
Yep.
you
Yep.
froze
Can you hear
your
me?
screen. Yeah, your screen froze for about 45 seconds. The
Okay.
last, if you want to start over with your answer, I mentioned about I was shocked that Epic missed the boat here. And do you want to start with that answer? Essentially, you said yes, they did miss the boat. They're trying to
Yep.
play catch up. Just can you restate that?
Sure.
Go ahead.
So, yeah, I believe they did miss the boat here. They're trying to play catch up now. They, really should have been able to have ambient AI built right in the system that was doing what Abridge does, or what DAX is doing, or any of these other vendors are doing. And a lot of these vendors have relatively small manpower sizes compared to Epic. So Epic, with its market share, with its underlying funding, should have been totally all over this in my mind, and they kind of missed the boat. And they didn't just miss the boat on the ambient side. I feel like they're playing catch up on the back end too. We're seeing them start to come up with like pulling out SDOH out of the notes, and it's coming, but it's not here yet. And we've been trying to figure out how to do a lot of that stuff on our own, because they don't have it. And even right now, they're piloting Slicer Dicer has, like you can just ask it questions and it's going to go into, and it doesn't really work as well as I would hope at this point. Now, some of that I think is because EHR data is fairly dirty data, and so if you're going to ask questions of a data model, um, you really it works better when the data model is a fairly complete, accurate, and uh, um, organized data model. And a lot of times in our EHRs, those data models aren't always that way. Um, so I think that the fact that the data is relatively dirty sometimes in some of the EHR data is part of the problem with the LLMs. But nonetheless, things like our PHDM, we're using, when I talk about overlaying a large language model on top of that so we can query, that's not Epic. We're using something outside of Epic to try to do that right now. And to me, that should just be inherently available in Epic, and it shouldn't be, these things shouldn't be priced exorbitantly either, because it's not like a lot of these things that you can get out there are not exorbitantly priced to do them. And so that's the other piece that's kind of something that I think is going to be need to play out a little bit better and more, I should say.
Fascinating. How sticky would you say, and I use that word intentionally, you relationship with vendors vary based on the stickiness. And by that I mean the difficulty of extraction from
Yeah.
that relationship. So where do you and a lot of CIOs have told me that basically the dynamic when they have to go outside of their core suite is they're looking for fairly short-term engagements so that they can go back in suite when that module is ready. Um, do you see that the same way, or where do you see the ambient AI in terms of the stickiness? Because I'm not looking to switch accountants every 2 months. I don't care if somebody's got a cheaper price. It's too sticky a relationship.
Um, that's a great question. And so and it's kind of two questions in one. So I'll answer the first part of yes. I think my approach within a pop health space, when we're trying to figure out if do I need a vendor to solve for a problem, is always thinking 1 to 2 year solution, 3 years at most, while I'm waiting for either internally a build we're doing or Epic to catch up and get us where we need to be so that we do no longer need the vendor. Um, the second piece is with the ambient AI piece with Abridge. Our providers love Abridge.
Yeah.
And so, I mean, it has been such a game changer for them. And so I do think that we're still looking as, if Epic comes up and says, well, out of the box, we've got this ambient AI program, that we would be seriously, and I don't speak for our CMIO for this, but I think we would be seriously looking at, can we switch? But it wouldn't be just a switch. It would be like piloting. It would be like, does this, like now you have to beat what we have, because it's got to be better than, or at least equal to what our providers have from an experience perspective.
Right.
um, Otherwise, you're going to have to have a lot of change management to work through with your
Yeah.
providers. um, because they don't want to go back.
So that's really fascinating, and I have heard in different discussions I've had in roundtables and webinars, people say when we have to put out a point solution, we let the providers know this is temporary to try and sort of head off that dynamic at the pass so they don't, fall in love. Like this is
Right.
temporary.
Yeah.
But, as you mentioned, uh, it's like switching jobs, right? If somebody's going to switch jobs, you're not going to do it for the same money unless you're really unhappy. You're not going to do it. You're going to do it for a premium because there's friction of change. There's the friction of changing something, so if you were to switch any kind of application, there's a massive friction cost with your users who, if they're happy with it, it's so any kind of change, the value has to more than account for that friction cost, right?
Yeah. For sure.
Fascinating. All right, let's go back a little bit to your internal population health platform. Take me through a little bit of the dynamic of the governance, the relationships, the discussions. I'm always interested in um, the bridge between IT and operations, that bridge, and you're one of those bridges
Yeah.
to marry the sort of enterprise view, the technical realities, some of the objectives of the enterprise view with the medical, the clinical on the ground objectives, and you're there to try and marry those two sides. So as pertains to this particular issue, this platform, take me through a little bit of the key relationships. We want to help people who want to go down this a similar path to understand some of the best practices that you found that worked well.
So I have really, really strong relationships within digital services and could not do what I do without them because I'm not building any of these and I don't have people report to me that are directly building these things. I partner extremely closely with our director of population health analytics, which is Maha Salahuddin, and she is the one who has the team underneath her that's building this out. I'm the connector, the translator between them and the clinical operations teams and the pop health operations teams to understand this is what we need to do strategically. How does that translate into what we need clinically in the data? And how do we need to have that set up in a way that's
Right,
going to be successful? And so
right,
there's a lot of back and forth dialogue, and there's a lot of synergies between what we do. Um, Likewise, I work with our applications director in our Epic standpoint. And I have a very good relationship with Mike Legg, who's our senior vice president of data and analytics for the system at Corewell. They build out they're deciding things like, are we going to use Snowflake or are we going to use Fivetran?
right,
Like I don't really care. I want
right.
that's their job to figure those things out. My job is to help them figure out, is the data good? Can we use that data? If it's not good, what do we need to do to clean that data up? Um, how do we need that data to be structured so it's going to be meaningful for the end user? And things like we talked about with the Epic registry versus in the Caboodle. My job was like saying we've got to have these built out in the Epic registry and flow down into Caboodle because I need to be able to have those same reports at the point of care for the frontline team that I'm then showing to a VP at an aggregated level in our Tableau. And they have to match, and so you have to have this, the data has to be starting in Chronicles and moving its way down, not built out in Caboodle, and then you're stuck. So that's some of the stuff that where my role comes in. As far as governance, some of the things that I was a broken record, but we use Agile when we build this out because it's not like I went in knowing, hey, here's the full structure of a population health data model that's going to meet all of our needs in 5 years. Let's just build it and they will come. I mean, that's not how
Right.
we did this. We went with Agile. We built it as the needs became clear. So we had some base foundational things we knew we needed to have in there, from a cost and utilization, a morbidity, a social determinants of health, mental health kind of stuff. But as requests came in for different build to meet workflow needs and to meet core business operations needs, we would build that, and I was kind of a broken record because I'd be like, is that in Caboodle? Is that in Slicer Dicer? Is that in our PHDM? Because what I have learned over the years is that when the application team would build something, they would build it, but it would just live in Chronicles and it didn't flow down into Caboodle, or they build it and the data wasn't actually captured discretely, even though you think it would, and then you couldn't actually report on it. So a lot of what I did early on was just making sure we had that closed loop, that full loop, so to speak, of the flow of the data from the build in the application down into our reporting layers so that we could actually get to the insights and report on that to our operation leaders. The flip side of that is that has now made data quality so much better. So for instance, we've got a COPD targeting list that's in our care teams are rolling out, and we have COPD dashboards. When we first start rolling that out, we get feedback all the time. This data is wrong. This is wrong. What about this? Where because the data is dirty when you start, because nobody was looking at it. So you start, and then you've got a process now where you've got clear data quality experts constantly feeding back to the system what's wrong with your data so that you can go and correct it and make sure it's right. And once you get it right, then it's easy to maintain, because if anything goes wrong, they're putting in a ticket instantly, and it gets fixed because they depend on data now to do what they're supposed to do in their job, versus it just being something that went to a director or a VP and was separated from the care team's work. Because the VPs and directors they're not working with that data on a daily basis. They don't know if it's good or not. But your physicians and your care managers will know in a heartbeat if it's good or not.
I mean, it's absolutely fascinating, all this stuff you described. It's pretty complicated. So what I was thinking as you were talking is there are certain decisions you mentioned. You used the snowflake example of that level of technology that you're like, I don't care, right?
Right,
So there's certain levels of technology that really don't get in front of the clinician that you don't really care about at all. So it's like
right,
IT, you do whatever you want.
right,
Then there's levels of technology at the application level, of course, where your users are interacting directly with it. And there you certainly you want to have part of that, you want to be involved in that conversation. And that's more of a collaboration with IT of here, sort of they know what's feasible from a technology point of view and security point of view, and you know what the users like and don't like, and that gets married. So in some areas it's do whatever you want, and in some areas it's now we're going to have a collaboration. And the interesting part about informatics roles like yourselves is what I love is, of course, we know what this is. It's someone who deeply knows the clinical operations and the clinical workflow, and deeply knows, to quite a degree, the technology environment, the Epic environment, and you can marry those two. So
yeah,
right? So, and Epic,
absolutely,
you could spend your whole life studying the Epic, right, infrastructure and how Epic works, and people have, and people do. There's careers, there's companies, there's consultancies dedicated to that one application. It's so massive. So it's a
correct.
full-time job, so to speak.
Yeah, absolutely. And there's different types of, and this is something I've kind of learned in my career, is there's different types of informaticists. There are some who are like John Lee, who
Yeah.
just
Yeah.
referenced, who go all in on understanding everything about Epic,
Yeah.
and they're they're an informaticist guru on Epic.
Yeah. Yeah.
And then there's, I would say I'm more of a hybrid. I'm like, I understand enough about the informatics part of it
Yeah.
to know what the end user is going to need and not need. And then I make sure I'm connecting with the people who are the experts within the application to get into the weeds with things.
Okay.
I understand enough about our data infrastructure and our data analytics and everything so that I can work with those teams and make sure they understand what we need to connect with our
Right.
informatics teams, because those are
Right.
two different, in our organization, those are two different teams. And so I'm
Right.
translating between them and making sure we're connected and we're working correctly and
Right.
creating a unified structure. And then likewise, I'm understanding enough about pop health and about pop health strategy and about what we need to drive in the organization so I can translate what the strategy is to what workflows we're going to need And then what does the EHR need to have and the analytics need to have to support those workflows? And so it's a triad of things that I'm really trying to keep myself working with and translating on a regular basis.
And sane. You're trying to keep yourself
Insane.
sane. Yeah.
Yeah.
So, the question there, and I won't keep you much longer. Um, we talked about all these dynamics. When we talk about governance, we talk about established groups of people that meet, in one sense, established group of committees, people that meet. You're trying to figure out, where you're involved in the governance and where maybe you have input on structuring different governance bodies. And you're saying, okay, there's this issue, there's this dynamic we need to work on. And in order to be productive, to move this forward, I need these people to meet together. I can't do one-offs all the time with the points, the individuals. Think of like the middle of like you're the hub and you got all your spokes. Like, yeah, you can have
Yeah.
one-off conversations with everybody, but sometimes you need to have all these people in a like at the same time. We need to sit
Oh,
down and talk, and some of those people are going to be internal, some are going to be external. And there's some situations where you say, to do this, I need all these people together, and I may need it one time, or I may need it regularly at certain intervals, or I may need it at intervals during a project. And then there are other times where you're like, okay, I can do point conversations here and sort of shepherd this information around. But this is important to your job being manageable, right? To get this stuff right,
absolutely.
right? So tell me your thoughts on that.
So you are 100% correct. In where the way that we operate is we have an agile train that is loosely based on safe, and that train we have a release train engineer, we have scrum masters, we have product managers, product owners. Um, I work with I sit at the lead business owner of that train for Pop Health. And so I work with all of our other business owners, and we have meetings that are on a regular cadence for us to meet to go over what is our roadmap? What do we need to have built? Do we have the features on that roadmap? Are we building up enough backlog to get you where you need? And have those conversations of prioritization on the roadmap based on our capacity of what we're going to build. And then the product managers work with the subject matter experts to make sure that we've got all those features roughly defined and filled out. And our product owners work with the frontline subject matters and analysts to make sure we've got the acceptance criteria where we need it to be to actually build those features. That whole process is on a consistent standard cycle. Every 10 weeks, we have a new pie and we're building out new things. And we're working through a set of recurring meetings that occur where we're working through the process to make sure that we're moving our work forward in an efficient and effective manner. And when you're talking about all these different stakeholders, they're brought into these different meetings depending on where they are in the level. Are they a senior leader business owner trying to figure out strategy? Are they a director, et cetera, who are trying to figure out how do they operationalize that strategy? Or are they a frontline person who's going to have to use that tool and try to help us figure out how does it have to actually work for them to get it done? And so there's those three layers that we work with to get things done.
All right, I lied. I'm going to ask you another question because I'm interested, and then I'm going to let you go. I promise.
Okay.
What fascinates me about governance and what I'm interested in is people talk about governance as it exists. Um, but how and who gets to adjust governance when it's suboptimal? So, for example, right? This is a good one, right? So
Yeah.
you've got a governance process and you finish a meeting and you're like, that got nowhere. We were missing someone who should have been here, or someone who's here is they don't need to be here. They didn't say anything. Actually, they don't need to be here. We can let them go. I mean, we're not going to get into the weeds of a difficult person who,
Mm-hmm.
that particular individual is gumming up the works.
Right.
We don't need to get into that level. But structurally speaking, who gets to fix governance? Governance isn't always perfect. It can be improved, especially as things change over time. So, what are your thoughts on that?
The business owners and the RTE of a given train should be the ones optimizing that governance of that train. In the same way that you do anything else agile, you're constantly iterating, you're constantly PDSAing. Is this working? What's working? What's not working? To your point, are these meetings effective? Are they not
Right.
effective? If not, why aren't they effective? What do we want to do different? Let's try a different experiment, see if it gets more effective. That's the way you get better. And that's why I said we're loosely safe. When we tried it safe initially and we tried to implement it as safe as set, that didn't work. And so we iterated the living daylights out of that to get to something that's kind of safe. You
Yeah.
know, we're about to revamp it again because we found that we were creating artificial silos between different application
Mhm.
teams with what we had set up. So we're going to be creating a larger value stream to try to break down some of those silos. Sometimes that requires, like when it's just our train, that was just us constantly iterating and making it better. When it's this value stream, that's us working with other directors. It's us bringing it up to our SVPs to make sure they're on board with the change we're going to make, and it's bringing up to other, business SVPs to make sure that they're okay with the change that's going to be made, and communicating up in an effective message why we want to do this. Why are we trying? We're asking them to make the change.
Right.
And I think we're fortunate to work for an extremely nimble organization that's willing to say, yes, let's make that change. If
Yeah.
they can see why it's not working, they're willing to say, do it and make it happen. But it's got to be coming from the people who do the work. You can't wait for somebody on high to come in and fix your governance structure. You've got to, like, it's a living organism in my mind, and you've got to constantly tweak it.
Yeah. Dr. Jarve, this has been an absolute pleasure. Really great conversation, wonderful advice for our listeners, and I definitely hope we can reach out to you in the future and get in touch again.
Same here. I really appreciate the conversation. So thank you.